Dr. Zoobia Chaudhry, who's from Johns Hopkins University and is an expert in the comprehensive management of weight gain and weight loss programs. And so we're very, very pleased to have her here. She's going to go over that with us. We've all encountered a lot of our patients who have developed weight-related issues, somewhat associated with the use of some of the antiretroviral therapy and other things. So, Dr. Chaudhry, welcome.
Thank you. Good morning, everybody. How are you guys doing? Good. I'm glad that I got like a fresh-minded crowd. Yeah, that's always nice. It's difficult when they put you like late in the evening. So I'm so happy to be here, and I'm so excited and inspired by like so far how many people I have spoken to, and I really appreciate you guys taking care of our patients with such diverse needs. So as Dr. Seg said that I'm an obesity medicine provider at Johns Hopkins, and I have been doing this for over a decade now. And what I will do, and I don't have any disclosures, but then what I would do today is just start really take a step back and talk to you guys about how obesity is a disease, not just a lifestyle choice, but then I would also request you to try to forget everything you know about obesity for next 30 minutes or so, and let's give ourselves like a really fresh look at what obesity means and what do we know from recent research. And then after, and I do spend some time on it, because once we kind of understand where science is on that, then a lot of our questions about, how we treat our patients, how we receive our patients, how long do we treat them, and what are the treatment options. A lot of those questions are actually embedded in that. And then we'll go over the treatment of generally the obesity, and then I will mention where we have some data on HIV, people living with HIV. So obesity as a disease, as you can, and I have put it here, there are, like in any disease process, right, how do we decide that it's a disease, right? And the first, obviously, how do we diagnose it, right? What are the characteristic signs and symptoms of that? And in obesity medicine, we have, obviously, what obesity is, it's increased adiposity, right? So increased fat is deposited in the body, and then how do we measure it is most commonly is through BMI. And BMI is a screening epidemiological tool. It was never meant to be a clinical tool, but nonetheless, that is what we use. And then in addition to that, we have clinical staging. IAS-USA has put together it's like, okay, BMI plus, right? So what metabolic comorbidities they have. So that in turn produces different stages of obesity, and it helps us decide how do we treat it, and I'll go over that in a bit. And then we have BIA, which is like body composition, like few offices you will find around yourself. Like it tells us, okay, this is the percentage fat you have, and then this is the percentage of muscle you have. And with the advent of new medications, we have been using it more and more. And DEXA is mostly used for research purposes, right? So that is how, so what BMI is, what cutoffs that would define the disease, what comorbidities, that is another way to define it, and then what percentage of fat anyone has in their body, that would define disease for us. And then how does it manifest? And many of us have, every other patient you'll probably see in the clinic would have this issue that they have either, any comorbidity like diabetes and cardiovascular disease. And what happens actually in obesity is that, this as fat deposits, especially around the visceral fat, it produces interleukins and adipokines. And that in return put people at risk for these diseases. So there are these, and then put in 17 different type of cancers. So that is kind of the metabolic consequence of obesity. And then in addition to that, there are physical consequences, right? Patients with osteoarthritis and incontinence and all of that. And then we know that people do have higher mortality if they have obesity. And then the part that is kind of where does it all start? How does it happen? I've left that to the last. Here you see here in yellow that, this is really, where is it? Yeah. So this is where I would focus my next 5-10 minutes of talk, like what are the abnormalities that happen in appetite dysregulation, and how is the energy homeostasis is altered. And I would go even further to explain, try to explain to you the normal physiology, because I know like I have reviewed, I teach medical students and residents and postgraduate trainees. We are not taught this, so we have to really start from the basics, right? So obesity is, as many of you know, that obesity is one of the more visible, diseases. A patient walks into your clinic, if they have hypertension, you can't tell until you look at their chart. You can't tell they have diabetes until you look at their A1C. But obesity, you can see, right? You can see, and that makes it a very visible disease. And then it kind of like over the years, we have kind of focused on that it is a disease that, if you just, it's a lifestyle choice if you just tip the balance in the other direction, right? If you eat less and if you move more, then all our problems would be solved, right? But then as we have gathered new information, and a lot of this information has actually come from patients who have gone through bariatric surgery, how the hormonal changes kind of help patients lose weight and keep it off, right? So that's one point. The other point I wanted to share with you that, if we understand like what make people eat, right? And when we ask if you can just eat less. So there are different types of, signals that come to us when we are hungry. There are hedonic inputs, right? So we're not only, right now we all have breakfast or lunch, we feel full, that's fine. But then, if you don't have had lunch yet, so your body is telling you, okay, it's time to go get some lunch. Right? So that's a physiological, that's a hemostatic, that you're low in energy, you're feeling low in your glucose levels, so you want to go eat more. But that's not the only time we eat, right? You're passing by a coffee shop or a bakery, you smell something, and it just smells so delicious, right? And you have to have it, and then that is one way, right? That is another way. But we are triggered by our environment, and then there is a liking part of it, right? If I can just have this, chocolate, I have this craving, and I'm just talking about it. I want to now have a chocolate after this, right? So if I have that, so those kind of receptors also, kind of engage and sometimes drive our appetite. And then there is executive function, right? How do we plan our day? Like if I have not eaten all day, like I was busy at work, I skipped breakfast, I didn't have lunch, then there are chances that I would stop on my way back to some fast food drive-through, and then I end up eating more, right? So those are the few, how do we plan our day, and the stress and the time management as part of that. And then comes the hemostatic, and then this is again, I would again, it's just like we're here, and then I'm slowly zooming in. I hope you are following me in that, right? So let's see like how our body regulates our appetite, right? And that is the homeostasis that we eat when we are hungry, right? So it's the different layers. So when we are hungry, our stomach growls, and you can remember from that, like growling, right? Ghrelin, like that goes up. That signal go to our brain, then hey, go seek some food, right? So that stimulates our appetite. And when you see once we go find food, we are eating, and then we have the hormones that are released that promote satiety. GLP-1, CCK, PPY, those are like short-term, like they block. And then again, the message goes to our brainstem that, okay, I have enough to eat. And then insulin and leptin come into the picture that kind of tell our body that, hey, we don't need to store any more fat. We have enough fat or what, right? But then there is a reward, right? So that's what I mentioned, like, so we feel full, right? So one is from the stomach stretching, and then like our brain registering, okay, I feel full. And these are this is how it normally works, right? But then you may ask that if it is such a tight system, why is it that, people's weight kind of go up, right? Why doesn't it stays where it needs to be? And that is where we find that, there over the last 150 years, how our environment has changed, that has pushed these hormones and how we receive it and how we interpret it in our brain has also changed. For example, one of the studies, it's from 1990s, tell us that patients who have obesity, their reward centers are hit later on, right? And then similarly, there is alteration in their ghrelin. And that is not the whole story, and I didn't go much detail into the other side of the story, which is the energy expenditure. That also changes once we gain weight, right? Or once we're trying to lose weight. What happens is that this ghrelin hormone that you see here, that actually becomes more stimulating. Like once people lose weight. So for every kg of weight loss, the appetite goes up by 100 kilocalories, right? So actually, if you're getting hungry here after losing weight, you will be getting hungry sooner, right? And then these are all subconscious things that are going on we don't have control over. So when your patient comes and tells you that I think my hormones are off, they're actually speaking the truth. It's just not the hormones we are thinking, thyroid and the other hormones. It's these hormones that actually resist the weight change, right? So these hormones that we have. So that is what has perturbed this this very tight system. It's our, there are different hypotheses. There may be inflammation of hypothalamus. There may be some neuron injury, or maybe permanent scarring of the glial tissue, right? So those are the things that has moved it to our new normal, that where our weight wants to be. And then there you see this is the genetic genes, and then our environment, kind of how it interacts with all of these, that kind of decides where our body wants to stay weight-wise, right? So just to summarize the causes of obesity, obviously we focus on personal choices, and that is true in any chronic disease, right? So for example, patients with hypertension, you want them to be on low salt diet. So that is a choice if I am having pizza versus if I'm having like a low salt salad, right? Because anything we eat out has a lot of salt, but that doesn't mean we stop treating them until you reduce your salt take. No medication for you, sir, right? We don't say that, right? We treat them, we understand that, and then there are environmental factors, right? And I don't want to overwhelm everybody with this, but this is something, and I'm not going to go over this whole thing, but I just want to give you a bird's eye view that it's not just our food choices. There is so many things in our environment, right? And then that environment, how it interacts with our genetic makeup that drives our food intake. I was explaining to somebody this morning that how my patients who live in Baltimore inner city, the grocery stores over there are not like the grocery stores that I have in my suburban neighborhood, right? So their aisles don't carry fresh fruits and vegetables. So that's one of the factors. And I'm sure, like as we've been heard, Dr. Chaudhry, that like the patients with HIV, these are the things that impact their access to care, their access to food. But that's not only thing that, obviously the genetic makeup and then other environmental factors, societal factors, and then psychological. And another thing I would mention that in one slide down, that how the medications we give them disrupt their appetite. So that's another factor that we have, right? So all of this information very shortly that I have tried to compact in like first 10, 15 minutes is that, it has helped us redefine obesity as a prevalent, complex, progressive, and relapsing chronic disease, which is characterized by abnormal or excessive body fat, which in return produces these interleukins and adipokines, which produces impairing of health. So understanding that helps us. And then these are a list of long medications and, that promote weight gain. So we are treating one thing, but we're also, right, a lot of these medications you see may be familiar with you, a lot of antipsychotic medications, and then, the HIV medications. And I remember so there are some reviews that are done that have added these medications. And then when I did a review, which was later on published in Annals, I added this section in it because as I see more and more patients and I looked at the data, I kind of oh, nobody ever really included that in the list of medications, but that is definitely, our patients who are coming to us and telling us, hey, I have done everything. Even if my patients who have gone through bariatric surgery, they do gain weight, and then we find out that one of their HIV drugs actually is making them gain weight. So what do we do about it, right? What do we do about it? That is something we'll talk about in a minute here, and then just again a little bit zooming in a little bit more into HIV antiretroviral therapy. That there are then again there are overall factors I've told, but then there are specific factors that in persons living with HIV face when they that promote their weight gain. So we know that people who have lower CD4 count, probably because they're starting at lower weight, they end up what they call overshoot in their normal weight, right? So they end up gaining more weight. And then there are the INSTIs cause more weight gain as compared to the NNRTIs. And then, in patients who are now, I don't think protease inhibitors are used that much, but it caused a very specific kind of obesity and problems. And then women, especially African American, are more at risk of gaining weight on these drugs. So all of these, again, are another layer that is added on people living with HIV, right? And then there are drugs, and these are the treatment naive, and I have, some of them gain more weight on certain drugs, and then as compared to others. So within the class, right? So INSTIs kind of cause more weight gain, but within the class, you can see there is more difference, and then you see here that. So where a little asterisks is that these are the ones where, patients are gaining almost 10%. So in a 200-pound patient, it is responsible for gaining at least 20 pounds or so of weight when they are on these drugs. So all of this information help us decide how we can help our patients lose weight. And in patients, in persons living with HIV, it increases their cardiovascular risk, and then diabetes risk and other abnormalities. And again, it's very hard to, given the data we have, it's very hard to tease apart what is really coming just from obesity and what is coming from the HIV drugs. But we know these are all contributing factors for our patients. And this is the kind of little, what I explained before. What are the reasons, right? So whether it is an inflammatory impact of the ART that is causing this, we don't know that, but there are some kind of in vitro trials that have shown that there may be some mitochondrial disturbances that are happening that make people gain weight when are they on these medications, right? So there are certain drugs that do that, and then again, as I said, it's as the drugs have developed to be better tolerable, they have become more effective, and then people return, what we call return to health, and then it further promotes weight, right? So there is some data now we have from the PrEP trials, and as I was reviewing it, that, those patients who are on PrEP, they will gain around 1 to 1.5 kg at the end of a 1 year or so, as compared to people who are treatment naive, like who have HIV, or who are like switching from one drug to another drug. That's almost 12 to 15 kgs. So that make me think, and we don't have any direct comparison or any other studies in that, but that makes me think that, having HIV disease certainly contribute additional weight gain as compared to people who do not have HIV yet. Yeah, so I'm hoping that we can put some dent in it once the as the prevalence of HIV is going down. But that could be wishful thinking on my part. So how do we approach this weight management? And again, there are no head-to-head comparisons in patients, in persons living with HIV and people who do not have HIV. So this is what we can extrapolate. And in my breakout session, I will go in a little bit more detail about that, right? So patients, so before we go into the specifics of that, even if you are not ready to provide care for obesity in your patients, there is always how we interact with our patients, because we know from this study that patients, and this is one of my mentors who conducted that at Johns Hopkins, that the people who speak with their providers about weight loss and did not perceive it to be judgmental, they definitely do better, right? And then what is it that make us judgmental about our patients, right? And we know that the providers, the healthcare providers, are cited the biggest source of stigma, right? And there was a study conducted on medical students, almost 4,000 plus medical students, that they showed that they have more bias against patients with obesity. The only thing higher than was people who were using who used to inject drugs, right? So all the biases as like patients with obesity was pretty high, like more than double. And it goes up as they kind of graduate from medical school, which is very sad, which we really need to work upon, right? And then, so how do we counter that? By increasing awareness, right? So explicit bias, as we have preconceived notions that, oh, this person has weight issues, they must be lazy, right? So we carry these kind of judgments with us. And as I said before, if we understood the background of it, then we could. And even if I tell this to myself, that even if I judge somebody, right, there's no need to be obnoxious about it, right? So, we all have that biases. It's just how do we manage our own biases? How do we understand? We may not ever be able to eliminate them, but we have to understand where my bias is originating from. I have a really, a touching story from one of my patients who came to me. She very educated. We have, she was in the board of education at one of our local counties, and then she would say that she was, whenever, and her blood pressure was like, she came to me for weight management, but her blood pressure was uncontrolled. And I was like, you have seen your primary care for this? And she says, yeah, but they never have the right cuff size for me. And when I go in and check, and they ask me, and this, she shared this me of like after 2-3 visits, that they would ask me to go because I wouldn't fit in their chairs, so they asked me to go wait in the car, and when it's my turn to see the doctor, somebody from the front desk would text me to come back in, and I felt so bad for her. And then obviously, they cry. Like my patients cry, we cry together about it, that how hard for her for just to get the treatment for hypertension. Obviously, it was, linked to her weight as well. So these are the things that patients feel we don't have, so we can change a little bit in our practice about it. If you have, and most of them, you'll see patients who are overweight and obese, they will sit behind you in the exam table, right? And then, we are typing on our computer. So there's like no eye-to-eye contact, right? So I tell my residents, and, obviously my clinic is built that way to accommodate patients of all sizes, but then having a chair that doesn't have armrest on the side, right, by your computer or by your desk, so they can sit. And you can see them as a patient. And then a lot of time, like I have so many stories, if I have time, tell you, like patients who had atrial fibrillation, and every time she went to the doctor, she was told, well, you have shortness of breath, maybe you can lose some weight and it would get better, right? So those are the things that we have to, train ourselves to. There are a few links that are given here that has more information on it, on implicit and explicit biases. So again, nobody is expecting that we kind of completely get rid of our biases, or we can ever, but we need to be aware, mindful of how do we speak to our patients, how do we set up our spaces to manage our patients. And then a quick overview, how do we treat, right? There is a tiered obesity management. Everybody over the BMI of 25 gets some advice to not gain the weight. If they have comorbidities, we not only manage those comorbidities, but we also, help them manage their weight. And then they do qualify for anti-obesity medications, and, that we can prescribe them, and we'll go over those, and Dr. Srivasan after me would talk more about that. So you'll get some introduction to those, and then there is bariatric surgery, right? So this is so offering advancing therapy along with lifestyle modification when indicated. That's how we do it. So what are those? So I'll quickly go over the steps, right? So behavior counseling strategies, right? So that's the first. And again, you don't have to learn all of this now to implement. I think it helps us to know what is at take for our patients to have success in their weight management, right? So, and then we see if we are actually providing that resources to our patients, and if we are not, then how can we? And then, then we can maybe cut them a little slack, that if we are not even able to provide them all of this care. So what the guidelines say that, everybody who is in obesity range, so BMI of 27 with comorbidities or 30, should be offered like a comprehensive weight loss program. What does that mean? That means that, they are able to see somebody, interventionist, every 2 weeks, right? So 14 sessions in 6 months, and then more than after that some. And then even in my practice that is solely for obesity medicine care, I cannot see them that often. I see all my patients every 4 weeks, right? So that's important for behavior change. For nutrition, focusing both on quality and quantity. And then we know that there's all these diet wars going on, like which is better and which is not. Whatever your patient can adhere with, that's the best thing that works for them. And then, and in that finding, like, what is the healthier option for them. And then obviously restricting calories to 1,200 to 1,500 for women, and 1,500 to 1,800 for men. And then physical activity. And I tell this to my trainees, students, that if you're going to forget everything from my talk, please remember this one thing, that physical activity is not the sole strategy for weight loss, right? So it helps with weight loss maintenance, and that's like to start with 150 minutes and go 100 to 300 minutes. So that's almost 50 minutes every day, right? So a person who's not doing anything, you can't expect that within a month they can. So we gradually introduce that, right? So back to the same diagram that we saw before, right? So if we say that we can only manage things with lifestyle, yes, we can do the hedonic inputs, we can manage those a little bit. We can manage the executive function by helping patients like meal prepping, counting what they're eating, and then tracking their food and beverage intake. But then, we need more help with this hemostatic eating, which obviously is impaired in patients with with obesity, right? And these are the different drugs, again, the same that we have. I think the most effective we have now that impacts this brain-gut axis, and you probably have heard, if not in your clinical practice from your patients, they're probably demanding you that we need to be using Ozempic, Zepbound, and then liraglutide used to be our mainstay, but now we have far more effective drugs than that. But then there are other drugs that are centrally acting, and then they require obviously monitoring and care for our patients, but they are available. And then there is one which is intragastric medication, orlistat, right? So these are the further categories. We can go over these further in detail in our breakout session, but these are the drugs that are FDA approved at this point. There are many more that are coming, but that's not only, right? So I understand there is issues with coverage, and maybe Ryan Whitegrind can cover some of the GLP-1s, we don't know, but that is certainly I would like to explore further. But there are some off-label medications, right? So Qsymia that I showed you on previous slide is a combination of phentermine and topiramate. And then so we can prescribe them separately, and they're pretty affordable, right? So if you get comfortable doing that. And then the other thing, there are no trials in persons living with HIV, but there are trials in other population, like patients who have been on antipsychotic drugs, or patients who are trying to quit smoking. And in those patients, we know that when they are put on metformin or Wellbutrin or topiramate, they actually reduce the weight gain. So I hope that somebody may one day do a trial in patients with HIV, like patients who are on ART, to see that if we also can prevent weight gain in these patients. But we know that from the other medications that promote weight gain, these are the few drugs. And then we have other anti-diabetes medications that also produce weight loss. And not all of most of them actually don't cause any hypoglycemia. So if it is covered, they can be used in patients who do not have diabetes, right? And then comes the bariatric surgery, considering that as an option, and it usually leads to 20 to 30% weight loss. And how do we decide that? That again, I'll speak that in my breakout session, right? So that is all I have, and I have, like, the red light is going off. So thank you very much.
Thank you. Yeah, thank you.
I don't have it.
Yes. Yeah, just sit if you don't mind. And then, okay, great. Thank you very much. I think we are making a lot of headway in understanding the biology and then finding approaches that might work. We'll hear more about that in our next talk. Let's see if people can come to the microphone or send in your cards. While we're waiting, there's that one hormone that I'm not sure I'm going to pronounce properly, but it's gepatide or whatever. It's the one that comes from the stomach that stimulates appetite. Yeah, that. Can you tell me a little bit more about that? And I can read that to you. Can you tell me a little bit more about that? And are there medications that might block production?
Not yet. We don't have. There was, so when leptin was discovered, right? So then it was pretty exciting, but that didn't pan out. So yeah, so if we could block the stimulating hormone or reduce its production, that would be great. And that actually comes from the fundus of the stomach. And some of the studies do suggest that patients who have undergone Roux-en-Y procedure, like where they kind of like limit that part of the stomach, it actually helps with that. So that is what we have so far. But we don't have any direct receptors that, there is one in development where it is glucagon is another, and it's an agonist. So it's very exciting. A lot of new drugs are coming in the pipeline. Yeah.
This is a question about the microbiome.
Yeah.
And we didn't really go into that too much, but I guess in the general sense, are there ways to change that with probiotics, or would things like the use of doxycycline for PEP, post-exposure prophylaxis that we're going to hear more about, other ways of, is there any evidence that changing the microbiome changes weight?
Yeah, I think when it started more than 10 years ago, when I started practicing this, there was a lot of excitement, and I personally have been very disappointed that nothing panned out of the microbiome world. We had so many experts at Hopkins initially, and but yeah, so nothing, so what, we can talk about it, but when you look at the recommendations from those researchers is also eating healthy, promotes the healthy microbiome, and that is, so taking extra, pills for like, that is not helping, yeah.
Right. One of the questions was, are the slides available? Yes. At
Yes.
the end of the conference, you'll be having a link to get access.
And I have added significant amount of notes to it, and I asked Fatima to make sure that the notes are included in your slides, so you can definitely be benefited from that, I hope, yeah.
That's great. You mentioned that a lot of times the patients will come in and say it's my hormones, and what I think they're thinking about is thyroid.
Yeah.
And obviously there's many more, but what about the role of thyroid in getting people euthyroid?
So we do aim for keeping people's thyroid between 2 and 4. And I have, but then in more than 10, 15 years that I have been practicing, I have not even seen a single case that, somebody's TSH was 10 and we brought it down to 2 and all their problems were solved. So it is definitely a component. Yeah, so you can check every time, they have like all these thyroid tests. Yeah, none of them ever, yeah. So we cannot, check ghrelin or GLP or any of those hormones. And I don't know what would we do if we check them. But, again, like microbiome, TSH, yes, it is important, but we have not been able to, yeah. And it is such a polygenic disease, as I showed, that, all of these little things kind of come together, and then, but then that doesn't always produce the desired results, yeah.
You mentioned the interesting finding that in the PrEP studies, that is among people at risk for HIV but not with HIV, that they didn't see the same weight gain. The question here is, did it matter whether they were taking a TAF-based PrEP regimen or a TDF, which is more appetite suppressive?
Yeah. I just am amazed, and all of you that they can remember that. Like I have to always look up, but if you look at the slides, I have mentioned that the link for the as a reference too. I don't remember on top of my head. I have to look at my slides myself which category kind of promoted, but it was like from 1 to 1.5 kg. So it's clinically. I don't think that's a significant difference, depending on which drug they were on.
And the fascinating one was with cabotegravir, which you would have expected to cause weight gain because it was in integrase, and it didn't to the same degree. Yeah. Yes, interesting.
Yeah. And then again, it's not just the drug. Obviously, it's like who's taking, right? So again, that factor that which patients would be more susceptible, right? So that also factors there, yeah.
This is about phentermine?
Phentermine.
Yeah, and does that mean lifelong therapy when you use that?
So FDA has approved it for 3 months use, and it was approved like back in 60s when we thought that patients just need, if I can just get my metabolism going, I will be fine, right? If I can just get a kick on my metabolism. So it's been approved since then, and I think after that they have never submitted any reconsiderations to that, but it has been approved in combination with topiramate for lifelong. So what the guidelines, if you look at the 2016 endocrine guidelines, it does say that if the patient and the physician feel comfortable, then it can be used for long-term use. And you have to look at your state rules. How do they understand that FDA rule? I have heard, like in Maryland, state of Maryland, I don't have any problem continuing, and I make sure patient's blood pressure is fine. If they have a cardiologist, they know. So we cross all the T's. And then, but then some of the colleagues from other states are like, they would stop it for 2 days and then resume it, right? So just understand what are the instructions from your local state, and then you can prescribe. But yes, in our practice, we have used it for long term.
So this is digging in a little bit more to the different antiretroviral agents and asking in particular about integrase. So let's say someone comes in, they start an integrase inhibitor and then they gain 10% of their body weight in a couple months. Does changing at that point, is that an indication to look for something else? And we have data that shows that change doesn't reverse or what's your advice?
Yeah, so the change does not, so one, I would always reach out to their HIV doc to see what are the other options. And I've seen in recent years, they're becoming more mindful. If patients do complain, even before they see me, they have switched around the drug. But to be honest, I don't think we have any data that reversibility shows or happens after we switch the drug. So that is why we have to be mindful in starting these drugs. And I actually see the same thing with antipsychotics, like patients who have been on Paxil for 10 plus years, which is the most weight gain causing, promoting SSRI. Yeah, just stopping that does not change. Yeah.
What about motivational interviewing? Do you use that, and is that what you'd recommend?
Yeah. So maybe we can do a workshop on like how do we counsel these patients. So motivational interviewing. So in some of one of the future conferences, I hope that we can do that. But motivational interviewing is definitely a tool that we use, and patients, you have counsel like for any patient engagement, right? So that is the tool we use, and alone weight. Motivational interviewing has caused around 2.4 to 2.8 kg of weight loss, but alone, right, without. And that is something, again, that may be 5% for a lot of people, and that helps with managing their diabetes and reducing their medications and stuff like that. But so we can definitely combine it with other treatments. Yeah.
Previous guidelines that talked about for morbid obesity, bariatric surgery as a front line. Is that changing with GLP-1 agonist type of drugs, or what's your success been with bariatric?
Yeah, so one thing I just mention here, language evolves on its own kind of terms. Over the years, we have stopped using the word morbid obesity, number one, because it has a lot of morbid, negative connotations to it. So that's just one point I didn't have time to make during my talk. But then the guidelines did change in 2022, which you would see on my slides that now it is with the BMI of 35 or above, and then with comorbidities it's 30 BMI. Insurances are still on the old system, so you would still see patients with BMI over 40 being covered for bariatric surgery, and or 35 with comorbidities. Yeah.
And you find that works pretty well?
It does work pretty well, but again, there is no one solution, right? So patients who undergo bariatric surgery, in 5 years or so, they do regain 50% of their weight, most of them. So having continued care, a lot of patients obviously come to me for management after that and being on the anti-obesity medications to counter with that. But I definitely see patients who have gone through surgery, they have easier time losing weight as compared to their counterparts who would not have surgery. So that definitely, because it manages that side of the, homeostasis side of the appetite. Yeah.
Mm-hmm. Do you make a distinction between visceral adiposity and general obesity, and do you approach it differently?
Yeah. Visceral adiposity is definitely patients, again, it's so around the waist, right? Yeah. So we do recommend measuring waist circumferences in patients who have BMI of 32, up to 32, right? Up till that BMI, we give it an additional +1 as a risk factor, but then below above that, it doesn't, then obviously the risk is increased so much that, it doesn't make a difference. So if you have a patient who has a BMI of 31, and then their waist circumference is, I think it's 40 inches for men, and then a little bit less for 38 inches for women. But don't quote me on that. I can't remember on top of my head. But then that adds more aggressive treatment for them. So it's a lower BMI. It's more of a risk as compared to a higher BMI. Yeah.
So this is about BIA devices, and you use these regularly. And are there any particular device that you recommend or prefer?
Am I allowed to say that here?
Yeah,
Like commercial?
I think so.
Yeah,
They asked
yeah.
the question.
Yeah, no, because the commercial products, when it come in, I try to stay away from all these things as much as I can. So InBody has good. I think that's the one we use, but they become dated, and then yeah. So InBody is the one I'm aware of. Maybe, you know.
So this is. I'm glad somebody raised this because I didn't hear it, but the use of growth hormone releasing factor, trade name Agrifta. Do you use that ever, or do you use it preferentially instead of a GLP-1 or other approaches?
So that's not one FDA approved treatment for obesity,
Right.
and yeah. So I think in last 15 plus years, I've never seen it. I get a lot of people using B12 shots, but yeah. So there's no data that kind of supports that, and neither does B12 shots. But yeah.
Great. Thank you very much.
Thank you very much.
Good
Appreciate it.
job. Well done.